he has double vision, I think, at 3 feet. So you adjust to the patient, but he's an extreme case. So usually 2 feet away, you're asking them, can you see that, my finger clearly? It's not doubled, it's not blurred. Then you're going to start coming in, you ask, tell me when it turns blurred. So I'm going to come in towards her nose.
Blurred.
So if it's blurred there, you might want to take a measurement depending on what you're actually testing for. So on a lot of our concussion patients, we'll take a measurement here. Then you say, tell me when it turns double. So I keep going in.
Double.
Okay, now you would maybe measure there. 6 centimeters is normal. So if they're 6 centimeters away from the ridge of their nose to your finger, that's normal. You're going to keep going in now, though, to make sure that their eyes go in. I just do a little boop at the end, so just make them not so mad at me. But you have make sure their eyes can go in. Make sure that when they come all the way in, one eye doesn't just flop out there, kick out. So even though they tell you when it turns double, still go in the full range, because you're still looking at that like ocular range ability for the eyes to go in. So again, I'm just coming in. Tell me when it turns blurred.
Blurred.
Tell me when it turns double.
Double.
And then you go all the way back in. VOR. Now you're testing more the VOR reflex. So everything else, ocular motility-wise, except for the head thrust that we went over before, tests more central nervous system issues. So you're looking for ocular motility is looking at central nervous system problems if there's a problem with them. So now we'll look more at the vestibular ocular reflex. And to do that, I do like a metronome because you want to see how fast it is. It should be 2 hertz. So you're going to ask them to repetitively shake their head back and forth like they're saying no, while they're keeping their eye on your finger at 2 hertz. And that is this fast. I better turn on my volume. So I'm going to give her something to focus on. So she's going to look at my finger, shake her head back and forth. She should keep it in focus. It shouldn't look like I'm moving my finger. It shouldn't look blurred. It shouldn't look double. And you're watching to make sure that her eyes stay stable. On people that have an abnormal VOR, to a greater extent, their eyes will actually jump off the target a couple times, or their eyes will go over their head, and then they'll come back.
So that loss of fixation, inability to fixate and hold their gaze on the target, that would be abnormal.
And make sure that their neck is in a really good position for this, because if they're here and they're trying to do it, and if you guys do it to yourselves, you'll see the difference. I feel dizzier if I'm in a slouch position. Now, you also want to check the vertical VOR, which is shaking the head in a nodding position. This would be problems if people have problems like on the treadmill or something where they're getting some vertical displacement, they would have problems with this. Ooh, that's weird. So that's just the repetitive VOR. The next one, so VOR cancellation is you're trying to test the position.
Oh, yeah.
So VOR cancellation, I can show you guys just on me, is the ability for you to cancel out that VOR. So you want to be able to move your head or your eyes with your head. So to test it on a patient, you'd have them look at your nose, and you're going to say, keep your eyes on my nose the whole time. And you're moving their head, and you're moving your body so that they keep their eyes right on your nose. So their ability to move their eyes with their head is their ability to cancel out their VOR. And that would show more central nervous system problem if you can't cancel out the VOR, so now you can't suppress that reflex. That would be more of a problem in the cortex. So that's VOR cancellation. And then the DVA is a good way to quantify the inability for them to focus. So here you would ask them, you would give them a chart. This is a special type of chart just for the DVA, but you can use a Snellen chart. You want them about 10 feet away. You ask them to read the lowest line they can clearly.
F-E-L-T-C-E-O.
So she's the second to last line here. Now, turn back on the metronome. Don't memorize those lines over there, Dr. Bennett. Sorry.
Memorizing the lines. I think some patients do that too.
Yeah. wanna grasp their head in a sturdy way, you don't wanna be shaking up here. You're gonna shake their head back and forth and then ask them to read the lowest line of pink there.
LEFODCT.
Good. So she only went up one line. 2 lines is normal, 3 lines is abnormal, anything above 3 lines and above is abnormal. So it's a good way to quantify. You can actually like write it down in your goals, you know, you want the DDA to come back to normal limits or